or 37. Yeah, please go ahead. The extraction is done a few months ago. I think the periapical, yeah, the extraction is done. This was before the extraction. So now it looks like how? This is a bone graft. We did socket preservation, yeah. Okay. Okay. Nadine, we have the cast. We have it. Okay, we will get the cast. What else? Okay. Okay. Okay, let's do a CBCT. All of you have access to the CBCT. Let's do the CBCT. Repeat. Abdullah. Okay. Is it big enough? Oh, you don't see this. How come? Oh, what I see, you don't see. That's strange. Ah, okay. I should get more screens. Okay. This is the CBCT of that section. As you can, as grafting with socket, it looks like it healed occlusion as a small void, which is probably a woven bone, the nerve. Let's now. So now what? Yeah. Do you have a? Let me give you a laser pointer. This one is a measure device. You can measure what happens. Yes. Want me to tell you how much bone? Sufficient bone? Okay. The only thing is, okay. Okay. Apply. Okay. In the CBCT workshop, you all or doesn't show up. Share come. Wow, good done. What did you?
Just minimize the font.
Oh, okay. All right. So what we have in and is, so what do you think will be the implant? This class two. See how the increases? Yeah. Then there is even beyond this. So anyway, the article for classification of this is free. There is a classification how you how bad is your, how careful you should be. Anyway, looking back to this, so if the minimum space you have is 12 millimeter and the height you have is 15 to be an implant for a second molar, press the button again because your laser is on. Yeah, 6 by 11. Wow, 6 is a little big. Don't you think 6 is big for an implant? Well, unless you're placing 7 millimeter implant. 6 millimeter diameter is not a very, see what happens with the bigger diameter. Beyond, like I think beyond 4.5, when you drill, the amount of heat you generate, the amount of vibration you generate is way beyond when something is 3 millimeter. You know how when we take a bone graft from the ramus to use it as a autogenous bone in different parts of the world, different part of the mouth. I used to use uh, a 4 millimeter diameter and a 3 millimeter. Uh, Instead of 2, 3 holes, I use the wide diameters of bone. That till today properly. I mean, but the discomfort and sensation disturbing the percent, but it's never the same as 3 and 3.5 diameter. So vibration gets while you're drilling, the cells which are receiving this much, they have to die and regenerate. It's gone goes beyond certain quantity, they don't regenerate as much. That will affect your osseointegration process. So then we go, not saying we are not placing 6.5s, we are placing. We have the big socket, we don't have to drill as much because the socket 6.5 millimeter implant is perfect. But when we have bone and we have to drill it, to drill a 6 millimeter diameter implant, when a 4.5 will suffice, probably is not necessary. We can always is good enough and functioning, and you have more bone around implant to biolect this implant from bone loss. You have less bone, you put a wider diameter implant, you have less bone, you have less chance of its own to regenerate. The thinner the bone surrounding the plant will have meaning itself. There are less workers maintain and clean and do all the chemicals. There are more workers. There are more lymphatic drainage. There are more cells. There is still within gym to maintain the process of all the cell, which is nourishment, lymphatic drainage, blood supply, and all those necessary activities which is required for the osteontome. Is that a statement? No, is this statement clear? Is anybody has a question on this statement? 2 meters is ideal. Okay. Once this law is confirmed by unanimously as a, now we come to what if I don't have 2 millimeters of bone? What should I do? Then the question comes, what is the next question?
Biological event, how it will support.
What?
How do we manage the width?
No.
How do we manage the patient?
No. What's the next question when you don't have 2 millimeters?
What's the next safest distance at which? What's the next safest distance at which?
No. What's the next question?
How much you have?
How much you have? What you have? You said you don't have 2 millimeters. Huh? Sorry for that. Before that, what is the next? No, the width of? No. Exactly. When you don't have 2 millimeters, you switch to the biotype immediately. I don't have 2 millimeters. Okay, look at the biotype now. Biotype, which means your soft tissue is 2 millimeters. Okay, go and look back at the bone. If your biotype is thin, that means less than 1.5 millimeter of soft tissue, okay, then you definitely have to think of augmentation. Augmentation of what? Either the soft tissue to make it a bone to make it 2 millimeters. Back to the bone. If you have 1 millimeter, you have bone. Still, the literature has shown that the bone will not because the soft tissue to tolerate the stress from your rectum. Okay. If you don't have the 1 millimeter, you just have to add bone. And if you are having less bone with it, maybe you should think of both. Maybe you don't want to do it in 2 different sessions or do it at the same time, doesn't matter. But try to get 2 millimeter of bone and a thick biotype. If you have 2 millimeter of bone, a thin biotype, it's okay. Now, is that a statement which you agree with? Now, is it practical? Yes. This is clinically understandable now. Now you know. You have few choices, and when you have a chance to stuff. Yeah? Where were we? Okay, this case, yeah. I think, yeah, 4 point, what system is designed for him? So we are placing a BioHorizon implant for this patient. BioHorizon, any of you know BioHorizon by heart? What are the lengths of BioHorizon? 9, I'm talking about length, 9, 10.5, 12. So based on the height, we have 15 millimeter. Based on the, and we don't have 4.5, we have 4.6. By either 10.5, 12 will work. If, when do you decide you want to go with a 10.5 versus a 12? Who wants to discuss this issue? Now you have two options. 4.6 by 4.6 by 10.5. Exact, thank you. If you want to be straight, you can go shorter. If you don't mind slightly angulating it, then you can go longer. But if you want to put it straight, you might have of perforating. So if you're placing it in an angle, you can use the longer one. Then you have to think of the restoration needs an angulated abutment. If you don't want to use an angulated abutment, then you go with the shorter, no angulated abutment, straight implant, straight crown. It's your choice. Now, you prepare for, say, a 10.5, and you place the implant at 10.5, okay? And you find you are not happy with the primary stability. Then you go with the 12, you change the angle slightly, and you go deeper, and then you, hopefully this time you will not over drill, you'll use expansion, because you can see there is not much of cortical bone in there, yeah? And then hopefully you get better primary stability with the 12. So what I advise is, plan for 10.5 by 4.6, be careful not to over drill, and if you get a good primary stability, God forbid, bone is extra soft, you have used the drill for too long, or whatever happened, you're not happy with the primary stability of 10.5, to go millimeter deeper and place a 12. Is that a way of treatment planning? So you already give yourself plan A, and you have looked into the possibility of something goes wrong. You prepared yourself for that possibility, and you ordered 2 implants. That thing, if it goes wrong, so you are during the surgery for B. This is how I always think what can go wrong, predict it, order. Yes. You're talking about this radiology? Yeah. What's the question? No, radiology was taken, the was taken when the tooth was extracted. Now the time has passed, and the bone generation has taken place with the augmentation, the socket preservation, and the quality of bone is not the same today as it was that time. Even though, even if it was the same case, imagine it was an immediate case, still there is enough sufficient bone to have primary stability. If you open the area and you find there is granulation there and you excavate it very nicely and you place your implant, that excavation is a stimulus for bleeding and it's a stimulus for bone formation in the gap. So there is, if you look 3D, once in the afternoon, you do the CBCT workshop, you'll place an implant there virtually. Yeah, once you place a virtual implant there, you'll see the space where the implant, still there is a gap. You understand? That gap is a sealed gap. The difference between a sealed gap and an open gap is, it's like a sinus. If you place the implant here, and this part is a sealed gap, that means the implant has blocked the occlusal migration of soft tissue in. That becomes bone very quickly. The problem is the gap which is in communication with the oral, that gap needs a membrane, needs protection, stability of the graft, a nice soft tissue closure. That's a different animal. But this scenario will quickly fill with bone because there is a blood clot, a closed container, titanium one side, bone the other side. What else can happen there? Only bone can happen there. Is that enough? Yeah? Yeah? Okay, now let us finish all the 9 cases we have, and then we will go to side. Okay, so this is one case for tomorrow. Mhm. I need to get used to this 2 screen. Okay, you guys can open your second case, or what's the second case? Ahmed Kishawar, very good. Okay, this is, let me show you one clinical slide because you might disagree with some of the plans that we have. Okay, the patient uh, doesn't, he wants to crown all his teeth, the anterior lower. Unfortunately, these lateral incisors, once you crown them, normally they are not, they require root canal treatment because of the dimension of the neck of the preparation. And normally they fit better in a bridge than a single crown. And in looking at the patient's health, we found that even though the patient thinks he's insisting on crowning them, we are not very sure if a bridge here, because even if we crown this, we're required to give him a bridge because he wants to close this gap. We find, even though these laterals are not mobile, but to place an implant in them will have a better prognosis versus placing a bridge on 2 laterals, which he doesn't accept a root canal treatment as well. To avoid the root canal treatment, the possible treatment, we are suggesting restoring this edentulous space with 2 implants either side, because the patient anyway doesn't like the shape of them. Now, what do you think? It's little? Okay.
Supposedly healthy enough to maintain.
Okay.
So good consent, good understanding, good explanation to the patient.
I agree with you. I just want to show you now the panoramic view so you understand what we are talking about. Okay, this is the same patient. So we're looking at the patient wants a bridge here. We are worried if we prepare the teeth, it might need a root canal, which the patient doesn't accept. Patient says, I do not want a root canal treatment. So what are the other options? No, the patient wants to crown these teeth for aesthetic reasons. Resin bonding not give to the patient. Yes, he wants to crown. He's come to crown. That's his wish. He wants to crown the teeth, the lower teeth.
Is it because of that issue?
Yes, and it looks ugly. He wants like a bleach color crowns. He's looking at Hollywood Smile because the maxillary we can control the color because it's all we have around 4